because I think so. You can just, we take like,
Can you hear me now, Dr. Leslie? Can you hear me?
yes,
Hear
yes.
you? Okay. Thank you for joining us this evening. Could you please put up your slides, your presentation?
Yes, can you hear me?
Yes, yes. I can now hear you
Oh,
clearly.
thank you very much. I apologize. Let me just share my...
It is okay. Can you please put up your slides? Thank you. As her slides are coming up, maybe I can introduce her a little bit so that everybody knows Dr. Anna. Dr. Anna Drobez is a dedicated and a compassionate anesthesiologist, and she's currently working in the area of perioperative medicine at the University of College London Hospital. She graduated with distinction in medicine from the University of Ljubljana in 2023. A fun fact is that Ljubljana is the capital city of Slovenia and also the largest city in Slovenia. So the Faculty of Medicine awarded her the Orazem Award for being a top graduate in the field of medicine. And she has also been awarded several other awards, including the Dean's Award for Excellence for Outstanding Academic Performance, the Press Seren Award for Research Work, and the Pleknik Award for Exceptional Academic Achievements in the subjects of anatomy, histology, with embryology and pathology. As a resident in anesthesiology, she worked in University Medical Center, Ljubljana, the Institute of Oncology, Ljubljana, and at St. George's University Hospital in London. During the COVID-19 pandemic, she was among the frontline workers at St. George's University Hospital in London. So in 2022, Dr. Anna Drobez excelled in a specialist examination in anesthesiology and critical care, which she completed with distinction. And she also earned the European Diploma in Anesthesiologist and Intensive Care in Vienna, Austria. Her exceptional interests are in pain management and perioperative medicine. She earned a certificate of medical acupuncture in 2023, followed by a diploma in medical acupuncture in 2024 from the British Medical Acupuncture Society. So Dr. Anna Drobez dedicates her free time to professional growth, ensuring she stays abreast of the latest research in the field of anesthesiology. So we are very, very glad to have you here today. And I'm very proud of you as a fellow lady, excelling in so many aspects of anesthesiology and in the academics of medicine. So welcome, Dr. Drobez. You may continue.
Thank you, Dr. Leslie. I will start with Habari Yenu. Welcome. So today we are going to speak about cardiac biomarkers in perioperative risk stratification. This is a very important and very interesting topic, and I will try to share with you the latest insights. And then later on we can discuss about our current practices and how we look after high-risk patients. Can you see my slides?
Yes, I can see your first slide.
All right, great. So 200 million people worldwide undergo non-cardiac surgery every year. And 5% of these people develop cardiovascular complications, which is a lot. And these cardiovascular complications are associated with adverse clinical outcomes, which means increased short-term and long-term mortality. More than 1 million people die within 30 days of non-cardiac surgery every year. And just looking at these numbers, we can understand how important this topic is. And what is that we can do? So prevention, early recognition, and prompt treatment of these adverse cardiovascular events are very important concern in perioperative medicine. I will talk now about importance of risk stratification. So risk stratification categorizes patients based on their risk level, enabling targeted clinical management. This process allows for individualized care, where higher risk patients would receive additional tests or monitoring. It helps as well to identify specific risk factors that can be targets for interventions, which leads to better patient preparation before surgery. And as well, accurate risk estimation is important for informed decision-making and patient consent regarding surgery and postoperative care. So we used different clinical risk prediction scores in our practice. I will just briefly mention the one that is the most widely used. This is Revised Cardiac Risk Index. And this index has 6 variables, and the presence of each adds 1 point. One variable is high-risk operation. The other one is ischemic heart disease, cardiac insufficiency, history of cardiovascular disease, diabetes on insulin, and serum creatinine more than 2 milligrams per deciliter. We calculate and add together all the points, and then we stratified our patients preoperatively in 4 classes. If a patient scores 0 points, it is class 1, which means that risk for cardiac complications is 0.4%. If patient scores 1 point, they are class 2, which means that risk of complications is 0.9%. If they score 2 points, they are class 3, and the risk of complications increases to 7%. If they score 3 points or more, they are class 4, and the risk of complications increase further to 11%. We have other risk prediction scores that we use in our practice, which are, for example, as well, American College of Surgeons National Surgical Quality Improvement Program Risk Calculator, and National Surgical Quality Improvement Program Myocardial Infarction and Cardiac Arrest. Are there any questions? I hear some sounds. No, all right. And apart from having clinical risk prediction scores, we sometimes want to measure things as well. And we use cardiac biomarkers to prevent and to evaluate cardiac risk for patients undergoing non-cardiac surgeries. A history behind cardiac biomarkers goes to the year 1954, when the first cardiac biomarker named aspartate aminotransferase was used. And high levels of this marker within 3 to 4 hours indicated an acute myocardial infarction. Then later on, we used lactate dehydrogenase, we used creatinine kinase, which were less specific, and coming to cardiac troponins I or T, which were better and more specific. And since 2018, we use high sensitivity cardiac troponins. Cardiac biomarkers are multi-purpose toolkit. They are not just used for cardiovascular disease risk identification, but they are used as well to identify metabolic syndrome, inflammation. They're used as well in the setting of COVID-19 to identify cardiovascular injury, post-cardiac surgery complications, and graft rejections. And here on this slide, you can see different types of cardiac biomarkers, not just troponins and not just high sensitivity cardiac troponins, but for example, in the bottom of this diagram, graft rejection surveillance biomarkers, exosome, microRNA. In the middle of this diagram, miscellaneous biomarkers, for example, serum uric acid or ischemia-modified albumin. On the left side, risk identification biomarkers, for example, myeloperoxidase, galactin-3, copeptin. And on the upper left side, metabolic biomarkers, for example, nitric oxide, and on the right side, inflammatory biomarkers as CRP, interleukin-6, interleukin-10, and others. This is a picture of troponin. Troponin is an integral part of the contractile filament in the skeletal and cardiac myocyte. The troponin molecules facilitate the interaction between the myosin and actin filaments. And troponin comprises three subunits, as we know, troponin T, which binds the troponin complex to the actin filament. Then there is troponin C, which is the calcium ion binding site, and the troponin I, which inhibits interaction of actin with the myosin heads as long as the intracellular calcium concentration is too low to initiate muscle contraction. And coming now to high sensitivity troponin assays. These troponin assays are considered, like every troponin assay that we have, if it's considered high sensitivity, if their coefficient of variation at the 99th percentile is less than 10%, and the proportion of measurable concentration above the limit of detection in the healthy population exceeds 50%. So as such, high sensitivity assays can detect troponin at concentrations 10 to 100-fold lower than the conventional assays. And that's why they allow detection and quantification in 50% to even 90% of healthy individuals. So high sensitivity troponin assays are more specific and sensitive for than normal troponin assays. Where can we encounter elevated cardiac troponin concentrations? It's not just in the setting of myocardial ischemia, but as well in the setting of tachycardia, hypotension, shock, sepsis, heart failure, pulmonary embolism, blunt trauma to the chest, chronic kidney disease, and acute stroke. So when we see an elevated cardiac troponin concentration, we need to have all these things in our mind, not just myocardial infarction. Now going to the latest definition of myocardial infarction, which is the Ford definition, and it is from 2018. In 2018, they added a definition of myocardial injury besides the definition of myocardial infarction. And what is the difference? So the term myocardial injury should be used when there is evidence of elevated cardiac troponin values with at least one value above the 99th percentile upper reference limit. The myocardial injury is considered acute if there is a rise and or fall or cardiac troponin values, but there are no other signs and symptoms. And myocardial infarction is defined as what we said above for myocardial injury, plus at least one of the following. So besides elevated troponin, we need to have symptoms of myocardial ischemia or new ischemic ECG changes, or development of pathological Q waves, or imaging evidence of new loss of viable myocardium, or new regional wall motion abnormalities in a pattern that's consistent with an ischemic etiology, or identification of a coronary thrombus by angiography or autopsy. Looking to this diagram, so when we encounter an elevated cardiac troponin value that is more than 99 percentile of the reference range, we ask ourselves if this troponin level is stable or if the troponin rise and or fall. So if the troponin level is stable, we go to the right side of this diagram. This specified chronic myocardial injury. An example of these are structural heart disease or chronic kidney disease. If there is troponin rise and or fall, we ask ourselves if there are any signs of acute ischemia. If there aren't any signs of acute ischemia, we go into the middle of diagram. This is then acute myocardial injury. And examples are acute which plaque rupture or plaque erosion usually. And on the other hand, if there is just oxygen supply and demand imbalance, we speak about type 2 myocardial infarction, which usually happen in the event of severe hypertension or sustained tachyarrhythmia. Just to remind ourselves of all the different types of myocardial infarction. Type 1 is the one we spoke before, spontaneous myocardial infarction, usually due to the rupture of the atherosclerotic plaque. Type 2 is usually secondary to ischemic imbalance, supply-demand imbalance. Type 3 is myocardial infarction resulting in death without biomarkers. Type 4A is myocardial infarction related to PCE, and type 4B is myocardial infarction related to stent thrombosis. Type 5 is myocardial infarction related to CABG. Couple of pictures for myocardial infarction type 1. We can see here a plaque rupture and erosion with occlusive thrombus, and can be as well plaque rupture and erosion without, with non-occlusive thrombus. And myocardial infarction type 3 usually happens if there is atherosclerosis and oxygen supply-demand imbalance, or if there is vasospasm or coronary microvascular dysfunction, or if there is non-atherosclerotic coronary dissection of the wall of the artery, or simply if there is oxygen supply-demand imbalance alone, for example, in anemia. The other biomarker I would like to mention today is natriuretic peptides, so brain natriuretic peptides and NT-proBNP. These peptides would be released when there is a myocardial stretch, for example, in diastolic or right ventricular dysfunction. And when the BNP or NT-proBNP are released, they increase glomerular filtration rate, they reduce sodium reabsorption, and they promote natriuresis and diuresis, so water coming from our body. They relax vessels, and they inhibit renin, angiotensin, aldosterone system. What is the difference between BNP and NT-proBNP? Pro-BMP is cleaved in the cardiomyocytes to the active BMP and the inactive N-terminal portion of BMP, which we call anti-pro-BMP. And in contrast to BMP, anti-pro-BMP is cleared only passively, which results in a longer half-life. And as for troponins, several assays are available on the market both for BMP and anti-pro-BMP. While the various assays for anti-pro-BMP use the same antibodies, and variations in the order of less than 10% can be expected across different populations. BMP assays presents variations up to 50%. We as clinicians need to be aware of this issue, for example, when interpreting values of BMP from different institutions. And another source of variation is biology itself, and BMP concentration may vary up to 30% among individual patients presenting a similar severity of symptoms. So in these settings, availability of previous preoperative values of BMP might be helpful for the postoperative assessment of potential dynamics in cardiac failure. Biomarker enhanced preoperative risk estimation might help us to sort information by the patients in cases in which conservative treatment is also a viable option, alert physicians to the necessity to optimize and eventually intensify medical treatment of known cardiac conditions, support choice of intraoperative cardiovascular monitoring and hemodynamic goals, and as well guide the approach to postoperative care. For example, monitored versus surgical ward and monitoring of postoperative troponin to detect silent myocardial ischemia, which we are going to be speaking later on. So why would we measure cardiac troponins before surgery and after surgery? There are two key aims. Preoperative cardiac troponins can be a tool of preoperative risk stratification. So based on the preoperative cardiac troponins, we can stratify patients in risk categories. And as well, we establish a baseline for interpreting postoperative troponin changes. So then when we have a value of troponin after surgery, we can always check what is the difference between the preoperative cardiac cardiac troponin value. And elevated baseline troponin is very common. 20 to 50% of patients undergoing major non-cardiac surgery would have elevated baseline troponin. And baseline values are then crucial for standardized myocardial ischemia monitoring. I will show you a couple of research papers just to help us identify how important it is to measure cardiac troponin in the perioperative medicine, and as well what these values, what these numbers, if we measure them, what these numbers tell us, especially if the cardiac troponin is elevated. So one article that I would like to share with you is about perioperative myocardial injury after non-cardiac surgery. So this cohort study was done in 2014 and 2015. They included 2018 patients which undergone 2,500 surgery. Median age was 74, and 42% of them were women. They looked at the incidence of perioperative myocardial injury, which was shockingly high, 16%. What was interesting that these patients that had perioperative myocardial injury, just 6% of them presented with typical chest pain. that we see in the settings of acute myocardial infarct. And ischemic symptoms were present in just 18% of people, but they had myocardial injury. And they looked at mortality rates. 30-day mortality rate was 8.9% if patient developed perioperative myocardial injury, versus just 1.5% if the patient did not develop perioperative myocardial injury. And not just 30-day mortality rates, but 1-year mortality rates were elevated in patients that developed perioperative myocardial injuries and 22.5% versus 9.3% in patients without perioperative myocardial injury. And what they as well saw is that similar 30-day mortality was regardless of additional acute myocardial injury criteria. So just having an elevated troponin without any symptoms, no ECG changes, no chest pain, just a detection of elevated troponin was associated with higher mortality rates, 30 days and 1 year. In patients with high cardiovascular risk, perioperative myocardial injury detected and quantified by an acute increase in high-sensitivity cardiotroponin plasma concentration is a common complication after non-cardiac surgery, and this occurs in 1 of 7 patients. So patients that have high cardiovascular risk going for non-cardiac surgery, every 7 patients would have increase in high sensitivity cardiac troponin, and which means that would develop a perioperative myocardial injury. This is another study that I would like to share with you, and it's about prognostic performance of preoperative cardiac troponin and perioperative changes in cardiac troponin for the prediction of major adverse cardiac events and mortality in non-cardiac surgery. They included 12 studies on cardiac troponins predicting short-term, which was less than 30 days, and long-term, which was more than 30 days, major adverse cardiac event or mortality in non-cardiac surgery. And key findings from this study was as well that preoperative cardiac troponins was predictor of short-term and as well of long-term outcomes. And perioperative cardiac troponin changes, they were strong predictor of short-term outcomes. Preoperative cardiac troponin sensitivity was 43% and specificity 86%. Other study, part of the vision group, looked at association between postoperative troponin levels and 30-day mortality among patients undergoing non-cardiac surgery. The results of this study were as well very interesting. This was a prospective cohort study, included 15,000 people through years 2007 to 2011. They measured troponin postoperatively on days 0, 1, 2, and 3. And key findings of this study was that elevated troponin, which was defined at more than 0.02 nanograms per milliliter, was as well a strong predictor of 30-day mortality. And in this study, they saw as well that the mortality rates increase with the increase in troponin. So if troponin was less than 0.01 nanogram per milliliter, the mortality rate was 1%. We speak about 30-day mortality rate. If the troponin was 0.02 nanogram per milliliter, the mortality was 4%. Higher the troponin, higher the mortality. If troponin was 0.03 to 0.29 nanogram per milliliter, the mortality was 9.3%, and with troponin more than 0.3 nanogram per milliliter, the mortality increased to 16.9%. So the peak troponin adds significant prognostic value for 30-day mortality. Just having this biomarker that we can take from our patient's blood on the day 0, 1, 2, and 3 postoperatively gives us a huge prediction of the mortality for 30 days. And we'll see as well that for 1 year mortality as well, and for overall mortality as well. What was interesting was that postoperative troponin elevations were strongly associated with 30-day mortality, and this was independent of the presence of additional clinical signs or any ECG changes that would fulfill the myocardial infarction. It would be like just elevated troponin levels. And they develop the term of myocardial injury after non-cardiac surgery, because they could not call this myocardial infarction because it would not fulfill the criteria for the fourth definition of the myocardial infarction. So they came up with a new term, myocardial injury after non-cardiac surgery, which we call MINS. Is defined as presumably ischemia-induced acute myocardial injury with or without clinical signs or symptoms, diagnosed by an elevation in cardiac troponin levels exceeding the 99th percentile within the first 30 days postoperatively. And the incidence of MINS is 8%, and more than 80% occur within postoperative day 2. So not immediately after surgery, but day 2. If we look again, what's the difference between the myocardial infarction and myocardial injury after non-cardiac surgery? As we said before, for the diagnosis of myocardial infarction, we need to have a rise and a fall of cardiac troponin, and then at least any clinical symptoms like chest pain, shortness of breath, new ST elevation or Q waves in ECG, or regional wall motion abnormalities. And for means, simply we need to have at least one postoperative cardiac troponin concentration that exceeds the 99th percentile, with or without any clinical symptoms, and this needs to happen within 30 days after surgery. And in patients developing means, 30-day mortality, 1 year mortality, and overall mortality is increased. That's what studies show. Going to risk factors for developing means. So they are patient-related risk factors. There are some relevant risk indices and preoperative test results that point to a higher risk. And then there are surgical procedure-related risk factors. Under patient-related risk factors, we have demographics as increased age and male sex, and cardiovascular risk factors such as smoking and dyslipidemia. Cardiovascular comorbidities, hypertension, diabetes, coronary peripheral artery disease, or cerebrovascular disease, and other cardiovascular diseases, atrial fibrillation, heart failure, or other comorbidities which are untreated severe obstructive sleep apnea or chronic renal insufficiency. Under relevant risk indices and preoperative test results, we mentioned before revised cardiac risk index score that can point us to that show us what kind of a risk a patient would have for non-cardiac surgery. Then we have stop bank risk score, which evaluates for obstructive sleep apnea. And then we have random blood glucose concentration, natriuretic peptide concentrations, BNP or anti-proBNP, neutrophil lymphocyte ratio, and reticulated platelet concentration, post-exercise heart rate recovery, and reversibility on myocardial perfusion testing. And as well, functional capacity, which we usually access with the Duke Activity Status Index score. What are surgical procedure-related risk factors? Are, as we know, emergency surgery, major surgery, peripheral vascular or aortic or major vascular surgery, and procedures that are longer in duration with large fluid shifts and blood transfusions. What can we do to prevent this to happen? So this article from 2023 lists a couple of things that we as anesthesiologists can do throughout the whole perioperative journey of our patients. Preoperatively, when we are doing their pre-assessment, preparing them for surgery, intraoperatively, when we are giving anesthetics, and postoperatively, when we are looking especially carefully for high-risk patients and in high monitoring areas. They came up with this diagram. So they said we can definitely do some preoperatively. We can assess risk factors. We can perform functional capacity testing. We can apply some risk scores, as we mentioned previously, the revised cardiac risk index score, and we can check for anemia. We can preoperatively look at what kind of medications patients are taking, if they are on aspirin, statin, ACE inhibitors. We'll look later on what the latest guidelines recommend about continuation or discontinuation of these drugs. And intraoperatively, what is very important is to maintain hemodynamic stability, to maintain normal glycemia and normothermia. Postoperatively, monitoring and early treatment is very important. They recommend testing cardiac troponins within the first 2 to 3 days after surgery, hemodynamically monitor high-risk patients, maintain hemodynamic stability as well and normoxia, and check for anemia. They suggest including technological advancement in all perioperative stages, which means using hemodynamic monitoring intraoperatively and postoperatively, and early multidisciplinary involvement in high-risk patients, which means to involve cardiologists in the prevention, treatment, and follow-up of patients that are at risk or that have developed a myocardial injury after non-cardiac surgery. Educate patients as well, being a mediator within the interdisciplinary treatment team. Looking more into details about what we can do as anesthesiologists regarding hemodynamic management. We all know that intraoperative hypertension causes adverse events, but current studies have not shown any consensus on blood pressure targets. So results from 3 randomized control trials are a bit difficult to interpret. IMPRESS trial said that maintaining systolic blood pressure more than 80 reduced risk by 25% in around 300 high-risk patients. Other study from Vanner et al., they compared maintaining MAP more than 60 versus MAP more than 75 in high-risk patients, and they show no benefit of maintaining a higher MAP. A POISE 3 trial included 7,500 people. They compared MAP more than 80 millimeters mercury versus MAP more than 60 millimeters mercury, and they have no shown benefit from tight blood pressure control. So optimal intraoperative blood pressure targets remains unclear. But just because we don't have an exact number, it doesn't mean that this is not important. So we all know that intraoperative hypotension reduces organ perfusion and is independently linked to postoperative organ injuries, means, and mortality. We need to be aware that even short episodes of hypotension can have significant effects. We talk here in minutes. What is interesting, the study showed as well that 1/3 of all hypotension episodes that occur during anesthetics would occur between induction of anesthesia and surgical incision. So this is this period where we have the most work and the surgeons are preparing, and this is the period where we really need to be very careful about detecting hypotension and treating it. So regarding targets, we know from studies that there are some thresholds which are associated with harm. So mean arterial pressure less than 65 millimeters of mercury or systolic blood pressure less than 90 millimeters of mercury for 15 minutes was associated with increased risk. And means is associated with a 30% drop from baseline mean arterial pressure or mean arterial pressure less than 65 millimeters mercury. In patients with hypertension, these MAP levels and systolic blood pressure levels are even higher. So takeaway message is that avoiding intraoperative hypotension is crucial to reducing postoperative complications. The other important thing that comes under hemodynamic management is tachycardia. Because tachycardia may raise the risk for development of means and should be avoided in patients at cardiac risk. Although, again, the threshold of harm remains unknown. But this risk can, for example, be mitigated through a comprehensive pain management strategy along the whole perioperative pain, because we all know that when the patients are in pain, they are usually tachycardic as well. Other thing that we can prevent is perioperative anemia. We sometimes forget to check HB and look for anemia before surgery, and then patients end up getting too many transfusions or unnecessary blood transfusions. Key findings are that hemoglobin less than 12.2 gram per deciliter is associated with increased risk of means, and anemia severity correlates with the incidence of means. For example, mild anemia, HB 11 to 12.2 gram per deciliter, is associated with 18.6% incidence of means, and moderate to severe anemia, which means if the HB hemoglobin is less than 11 gram per deciliter, the incidence of means increased to 28%. So which means like every 1 in the 4 patients. Lower preoperative hemoglobin levels significantly increase the risk of means, and this is something that we can that can be avoidable. Under metabolic management, we'll speak about temperature. The studies done and look at aggressive warming to 37 degrees Celsius did not reduce the incidence of myocardial injury, cardiac arrest, or mortality compared to routine warming to 35.5 degrees Celsius. So maintaining a core temperature of more than 35.5 degrees Celsius during surgery is sufficient for patient safety. And glycemic control. Increased blood sugars levels more than 180 milligrams per deciliter or more than 10 millimoles per liter have been shown to be associated with means. So maintaining normal glycemia in the whole perioperative period is very important. We will look now into guidelines, 3 different guidelines from 3 different societies worldwide. One is guidelines from Canadian Cardiovascular Society. These guidelines are all on cardiovascular assessment and management of patients undergoing non-cardiac surgery. The Canadian guidelines are from 2017. The European guidelines are from 2022, and the most recent guidelines are from American Heart Association from 2024. American guidelines, we will look at what these guidelines say about choice of anesthetic techniques. And sometimes there is debate if the volatile-based anesthetic agent like sevoflurane inhalational anesthesia is better than total intravenous anesthesia TIVA for patients that have high cardiovascular risk. But the recent guidelines say that there is apparently no difference in associated cardiovascular events if we choose volatile-based anesthetic agent or if we use total intravenous anesthesia. And the same is, there is no a major difference in associated cardiovascular events if we choose neuroaxial anesthesia or general anesthetics. What they say about different drugs. So statins. The guideline says that in patients currently on statins and scheduled for non-cardiac surgery, continuation of statin therapy is recommended to reduce the risk of major adverse cardiac event. So we continue statins. And other important thing from these guidelines is that in statin-naive adult patients who meet criteria for statin use based on ACCVD history or 10-year risk assessment and are scheduled for non-cardiac surgery, perioperative initiation of statin is recommended, but with the intention of long-term use. So in this subcategory of patients, it's recommended to start statins preoperatively. And so with statins, we either start them if in this subgroup of populations, or we continue them. So we don't discontinue statins. For beta blockers, so the guidelines say that in patients on stable doses of beta blockers undergoing non-cardiac surgeries, beta blockers should be continued throughout the perioperative period as appropriate based on the clinical circumstances. So to be continued. In patients scheduled for elective non-cardiac surgeries who have a new indication for beta blockade, beta blockers may be initiated far enough before surgery. This is important, optimally more than 7 days. So if there's a new indication for beta blocker, we need to start them more than 7 days before the surgery. And the third thing is that in patients undergoing non-cardiac surgery and with no immediate need for beta blockers should not be initiated on the day of surgery due to increased risk of postoperative mortality. So if there is no need for beta blockers, and definitely we don't start beta blockers on the day of surgery. There is an article that looked into the effect of continuing angiotensin converting enzyme inhibitors or angiotensin II receptor blockers on the day of the surgery on myocardial injury after non-cardiac surgery. So this study evaluated the effects of continuing versus withholding ACE inhibitors 24 hours before surgery on the means and blood pressure. And what they found is that means incidence was higher in the continued group, 7.4%, versus in the withheld group, 6.4%. This might be due to intraoperative hypotension because mean arterial pressure less than 65 millimeters of mercury was higher in the continued group. But there was no significant difference in overall outcomes or 30-day mortality. And the new guidelines, American guidelines, suggest that in select patients on chronic renin-angiotensin-aldosterone system inhibitors for hypertension, if the indication is hypertension, and if they undergo elevated risk non-cardiac surgery, omission 24 hours before surgery may be beneficial to limit intraoperative hypotension. So if these drugs were prescribed for hypertension and if the patient is undergoing elevated risk non-cardiac surgery, we should consider omitting these drugs 24 hours before surgery. On the other hand, in patients on chronic renal angiotensin aldosterone system inhibitors for heart failure with reduced ejection fraction, perioperative continuation is reasonable. So we continue these drugs in a subpopulation of patients with heart failure. That's the recommendation. What the guidelines say about aspirin? So in patients with chronic cardiac disease with prior PCE undergoing elective non-cardiac surgery, it may be reasonable to continue aspirin in selected patients, but risk of cardiac events needs to outweigh the risk of bleeding. And the other recommendation is in patients with coronary artery disease but without prior PCE who are undergoing elective non-carotid non-cardiac surgery, routine initiation of aspirin is not beneficial. And now we are going to look at these three guidelines again and just see what they recommend regarding monitoring cardiac biomarkers in the perioperative settings. First, we are going to look at the Canadian guidelines from 2017. We will go on the right side under the elective surgery, and they recommend first assessing the perioperative cardiac risk. So risk stratification with revised cardiac risk index, that's the one that I mentioned in the beginning. And then based on this, they want to understand if the patient is high risk. So if a patient is more than 65 years old, if revised cardiac risk index is more than 1 point, or if they are age 45 to 64 years but with significant cardiovascular disease. These guidelines recommend to order NT-proBNP or BNP preoperatively as a preoperative assessment. And then based on the value of NT-proBNP or BNP, then they recommend what to do in the post-operative settings. If the NT-proBNP and BNP are negative, they do not recommend anything, any additional post-operative monitoring. But if the NT-proBNP or BNP are positive, which means elevated, or if they are not available, in this high risk, in this group of high risk patients, they recommend measuring troponin daily for at least 2 to 3 days, and recommend as well obtaining ECG in PACU and consider in-hospital shared care management. So they strongly recommend measuring troponins. I have almost finished. So just going through the European guidelines. European guidelines say that in patients who have known cardiovascular disease or cardiovascular risk factors, which means they are older than 65 years old, or if they have symptoms suggestive of cardiovascular disease, it is recommended, so they recommend to measure high sensitivity cardiac troponin T or high sensitivity cardiac troponin I before intermediate and high risk non-cardiac surgery. So before surgery and 24 hours and 48 hours afterwards. As well, they recommend considering measuring BNP or NT-proBNP before intermediate and high-risk non-cardiac surgery. American guidelines as well. So they say that in patients with known cardiovascular disease or age more than 65 years or age more than 45 years but with symptoms suggestive of cardiovascular disease undergoing elevated risk non-cardiac surgery, it is reasonable to measure BNP or NT-proBNP before surgery to supplement evaluation of perioperative risk. As well, they say that it's reasonable to measure cardiac troponin before surgery to supplement evaluation of perioperative risk in this same subgroup of patients which are high risk. And in patients with known cardiovascular disease, symptoms of cardiovascular disease, or if they are age more than 65 with cardiovascular risk factors undergoing elevated risk non-cardiac surgery. As well, they say that it might be reasonable to measure cardiac troponin at 24 and 48 hours after surgery, just to identify myocardial injury. So all these guidelines, so Canadian guidelines strongly recommend, European guidelines recommend, and American guidelines as well say that it's reasonable to measure troponins and BMPs in this superpopulation of high-risk patients. In patients undergoing low-risk non-cardiac surgery, routine postoperative screening with cardiac troponin levels is not indicated without any signs or symptoms suggestive of myocardial ischemia or myocardial injury. So what I would like us to discuss is what actually we do in our clinical practice. Do we calculate revised cardiac risk index? Do we measure troponins preoperatively? Do we measure troponins on day 0, 1, 2, 3 postoperatively? Do we measure anti-proBNPs and BNP preoperatively? And what do we actually do during our preoperative assessment, what we do intraoperatively, and what we do postoperatively to reduce the cardiac risk? And if there are any other questions, I'm happy to answer them. So thank you very much for your attention.
Thank you very much for your precise presentation. It's a lot to think about, and it has definitely been a learning point for all of us. Are there any questions, suggestions, additions? So far, there are no questions on the chat. Anyone who wants to unmute and ask a question?
Right. I think it would be just nice to hear from someone how they approach these patients in their clinical practice and what resources are available. Just maybe that we can start a discussion if anyone wants to share. That would be greatly really appreciated. I can maybe add that in our hospital, where I currently work at University College London Hospital, we are still not currently, not routinely measuring cardiac troponins and BMPs in the perioperative settings. But based on the current guidelines, we will start with the project and the research that will be measuring cardiac troponins in the perioperative settings, just with because there is so much evidence that if we detect elevated cardiac troponins post-operatively, that this is associated with 30-day and 1 year and overall mortality. and that actually we can't detect perioperative myocardial injury without measuring cardiac troponins because there are no any other symptoms. So I find it like a very interesting area for research and as well for optimization of our current practice.
Thank you, Dr. Anna, for that. Dr. Njogo has a question. He has lifted his hand.
Thank you for the beautiful presentation. I'm just wondering, now considering that we are in a poor resource setting, in other words, some of these tests don't even exist in most of the hospitals, but assuming that you are practicing in a hospital in a poor resource setting, with the availability of the test, of course, is there any study which has demonstrated unequivocally that the testing of pro-BNP or BNP as such will help you reduce the risk of development of the myocardial injury following and cardiac surgery? Thank you.
Yeah, thank you for your question. So as far as I'm aware, for BNP and anti-pro-BNP, it is more that so preoperatively, as we saw in the, for example, in Canadian guidelines, this marker helps us to identify the patients that are already at a high risk. To stratify them is if we need to post-operatively measure cardiac troponins or not. So in the guideline, guidelines are based on a couple of studies, and which shows that if there is a patient that's already a high risk, as we said, it's more than 65 years old, or if it's younger, that it has other cardiovascular risk factors, and if during our preoperative assessment, when we measure blood pressure, blood glucose, if we have the capacity to measure BNP or anti-pro-BNP, and if this is positive and elevated, we need to look after these patients more carefully, and it's suggested that we measure troponin on the day 0, 1, 2, and 3 just to detect these perioperative myocardial injury. And it depends on the hospitals and on the settings, because these biomarkers are not available everywhere, and not even in the hospitals that could afford it, because sometimes just the processes are not there's not in the local hospital guidelines, they might not be this process, but it is, I think it's coming more and more into more and more research is done and shows that these biomarkers are very important for risk prediction, and as well for help us to recognize these patients and treat them earlier. So I believe they're going to be in the next years more available, I hope.
Thank you for that. Dr. Umani has a question. He has raised his hand. Please go ahead.
Hi, thanks, Anna, for your discussion on these biomarkers and their use in perioperative management. Okay, in the center I work, where we do cardiac surgery, we don't per se routinely have the test capability to do these cardiac biomarkers, but there was something you had mentioned on the revised cardiac index score, which is something we get to use, particularly if it's those patients with coming for cardiac disease for non-cardiac surgery. Generally, does not per se really like change the overall outcome, but probably helps in guiding the anesthetist to navigate major intraoperative events. But the testing capability may still quite be a challenge for our patients in terms of costs related with them. But what I would just say is that for CABG patients, which sometimes we do, particularly those with blocked coronary vessels, maybe they need grafting. Usually, particularly, we usually get to do follow-ups, particularly on getting to know how their wall motion abnormalities postoperatively with the echo, and if there are any other concerns, maybe we can be able to like measure troponin level. That's my comment.
Thank you, Mani, for your comment. And especially you said that you use revised cardiac risk index as just as a guidelines as what it is, just to give you as an anesthesiologist some impression on what kind of a patient like we are looking in front of us. And yeah, as part of my presentation was as well encouraging using what we have and what we can measure, and it doesn't cost anything. That's why I included this revised cardiac risk index as well, because I'm aware that cardiac biomarkers and other things are not available everywhere. And even in hospitals, as I said, that they would have the capacity and that they would have money to measure these, they're still not measuring these but it's more and more research is coming. So in the next year, that's definitely going to I believe be more available, and there'll be more studies. So hopefully we will be able to use these biomarkers in the favor of our patients.
Thank you.
I just see as well a question in the chat. Did they mention anything about diabetics, metformin, and insulin use affecting cardiac risk? Yeah, that's Karen, that's for sure. Diabetics, especially if they are on insulin, have a higher risk, and so this is part of the revised cardiac risk index. One of the six things that we measure as part of this index is one is diabetes on insulin. So that's definitely very important. And we as well said that maintaining normal glycemia is important to prevent perioperative myocardial injury, which is something that we as anesthetists keep a look on during anesthetics.
Thank you for that. Dr. Janak says that this is an excellent presentation and she thanks you. Any more questions, comments? Okay. I would like to thank you, Dr. Anna, again, for the lovely and excellent presentation that you've made. And I'd like to appreciate you for the work that you've done. And I'm sure you've inspired one or two people to think about perioperative medicine, as well as pain medicine, as well as acupuncture as well. So I thank you. And I think without any further remarks, we can close the meeting.
Thank you very much, Dr. Leslie, and thank you everyone for listening, for your attention, and being here for your time. Thank you very much, and I wish you all the best.
Thank you to Daktari. Have a good evening.